Hello and welcome, Tom Engel. I am the Assistant Medical Director from Milwaukee County EMS in the Office of Emergency Management, here to give you your 2022 Standards of Care manual updates for the online medical control provider. How do we actually get to where we're going? So our drivers of change really stem from the continuous quality improvement process that we do throughout the county every year. We use provider input, we use EMS physician input, ensure that we create evidence-based guidelines, all done through our EMS GAP subcommittee that has EMS providers, EMS physicians, educators, and OEM staff, all to create the best standards of care for our patients. What were our big initiatives for 2022? We wanted to be more aggressive with the use of norepinephrine, specifically in post-arrest ROSC patients, as well as patients with shock, improve our guidance for needle thoracostomy skill in the field, improve our management of trauma patients with more delineated skills for our life-saving interventions, create an epistaxis guideline, really provide more clear information for OBGYN management for our providers in the field, also surrounding childbirth as well as newborn care, ensuring that we update all of our pediatric documents so they are meeting current standards throughout the country, creating an interfacility transport guideline, ensuring that we update from old to new terminology, specifically surrounding BRU, which was formerly ALTI, as well as mechanical circulatory support, which was formerly LVAD in our system. And then importantly, removing the term excited delirium and replacing it with delirium with agitated behavior, as we have recognized that multiple overarching societies recommend this change due to the negative connotations surrounding the term excited delirium. So what are some specific updated practice guidelines? The ones that are underlined, I will cover individually. However, I will walk through a few of the non-underlined ones to give you the highlights. Acute coronary syndrome, we have moved to the use of fentanyl after 3 doses of the nitroglycerin and continued pain in your patient. For bronchospasm, we have added no air entry presumed due to bronchospasm, essentially silent chest, to the inclusion for management of bronchospasm, and then provided more additional guidance on COPD patients, specifically surrounding hypercapnia. For cyanide poisoning, we have updated our ribbon to ensure adequate inclusion of patients for the use of cyanokit, including patients who are unstable and patients who are post-ROSC who are believed to have been exposed to cyanide. We also have information surrounding the carbon monoxide poisoning on this, as well as possible destination. If used a cyanokit and no trauma and burn, destination would be considered for St. Luke's for hyperbaric therapy possibility. In the poisoning guideline, we have removed glucagon from beta blocker toxicity and focused on shock with the use of vasopressins as needed. For shock, as I said, we are more aggressive with the management of hypotension with the use of a second IV, ensuring pressure bag utilization and time delineated access and infusion of norepinephrine. For our trauma patients, we have moved away from the ABCDE algorithm into a March E algorithm: massive hemorrhage, airway, respiration, circulation, head injury, and expedited transport, to try and ensure more improved management of trauma patients in the field. For traumatic cardiac arrest, we have updated our termination of resuscitation guidelines to ensure that all patients who have trauma resuscitation from arrest worked in the field utilize online medical control prior to termination. Knowing these things, we're going to jump into some of the specific portions for the underlined practice care guidelines here. For epistaxis, we have a new guideline. It's pretty straightforward: managing the airway and treating for shock, position of comfort with the head tilted forward, blowing out the clots, and then direct pressure for 15 minutes. They don't have any specific medications to treat this in the field. For BRU, which was previously ALTI, we provide indications as to when the provider should be considering BRU, things that would make them not consider BRU or move them to another practice guideline, and then provide information as to what patients would be considered high risk, which require ALS transport to the hospital. Patients who are considered not high risk would still be required transport to the hospital, but could go by any modality, specifically only BLS or ALS. For mechanical circulatory support, this used to be just LVAD. However, we all recognize that within our system, patients have multiple mechanical circulatory devices. Specifically, we break this up by pulsatile and non-pulsatile. Pulsatile devices are the total artificial heart, essentially a metal chamber in the chest, and non-pulsatile devices include LVAD, RVAD, as well as BiVADs. It initially provides information as to how you obtain vital signs, what you're looking for, how to assess the patient, and what would come up on your 12-lead EKG. We then provide information as to the most common complications from these devices, how to treat them, and where the patient should go. This is a very nice algorithm here if you have a patient who has mechanical circulatory support and you're providing online medical control for the EMS provider. For the OBGYN guidelines, this is a very, very large guideline and a complete overhaul. What I want to point you to is that we have done a good job in these new guidelines of breaking this up by vertex and non-vertex presentation of a delivering mother, vertex being head down, non-vertex being not head down. Within each one of those linkable aspects of the initial document, it can move you to further recommendations that include the complications that could occur in those patients, specifically nuchal cord, prolapsed umbilical cord, shoulder dystocia, prolapsed bulging amniotic sac, as well as in-call birth, or essentially a child delivered still in the amniotic sac. We have the non-vertex, which is all in the same format with additional updates for the most common emergency presentations for these delivering mothers. And then we have an updated pediatric newborn care assessment, which focuses on obtaining APGARs at proper timing, focuses on BVM ventilation if having to resuscitate a newborn with removal of advanced airways in these patients, as we believe that BVM will offer the best resuscitation for these newborns, and then adding in an APGAR scoring chart. Remembering that on this OBGYN guideline, you can hyperlink to vertex, non-vertex, as well as the newborn care assessment. For patients with croup, two quick things that we added in was if the child has a croup severity score of greater than 4 or equal to 4 that the provider is calculating in the field, they should be receiving nebulized epinephrine as well as dexamethasone at the same time. And then also ensuring that we are keeping the child calm to prevent discomfort, which can exacerbate croup. And then epinephrine nebulized is an ALS scope. So only ALS providers would be utilizing nebulized epinephrine in the field. For bronchiolitis patients, two big things. We're highlighting the frequent and aggressive suctioning with ideally an H French suction catheter, or some crews only carry the bulb suction. And then ensuring that crews are not delaying the initiation of respiratory support, specifically ventilations or oxygen, if the child is sick enough to provide medication. So ventilation and oxygenation comes prior to medications in patients with bronchiolitis. In adult cardiac arrest, couple quick updates that we added in. We were more delineated or definitive as to when calcium gluconate would be required. Calcium gluconate would be required based on our new hyperkalemia guidelines. Touching on our hyperkalemia guidelines, you should take a look at them. They essentially say a patient who is a dialysis patient, as indicated by a fistula or a dialysis port, having a prolonged downtime, or a crush injured patient who has EKG changes that are of wide complex rhythm, or severe bradycardia, would require the dosing of calcium and then redosing of calcium at 30 minutes. So in cardiac arrest, if patients meet that criteria, they would require calcium, as can be administered by the EMS provider. And then noting that sodium bicarb requires an online medical control order, as routine sodium bicarb administration in cardiac arrest has not improved outcomes. And then noting once again that Narcan in cardiac arrest would not be indicated. And then clarifying that end-tidal CO2s that are either persistently 0 or intermittently 0 require online medical control consultation for troubleshooting prior to termination of resuscitation. For pediatric patients, we also added in the post-ROS guidelines at the bottom to force our providers to jump to the post-ROS guideline, as well as ensuring that they are contacting online medical control for intermittently 0 or persistently 0 end-tidal CO2s. In traumatic cardiac arrest, we are ensuring that our providers are immediately performing the life-saving interventions, or LSIs, prior to the consultation of online medical control. We also provide further information as to when those LSIs would be indicated in specific patients. In ROSC patients, this is a pretty big guideline change. We are prioritizing post-ROSC care prior to patient movement. We all know that patients in the field who get ROSC, crews often want to immediately move to the ambulance. We would like them to focus on oxygenation and ventilation, treating hypotension aggressively with normal saline infusions, the use of a pressure bag, the use of a second IV, and then after 10 minutes, if continued shock, initiation of vasopressors, specifically norepinephrine. With norepinephrine, we have gone and been more aggressive with its initiation and up titration. It is starting at 0.1 micrograms per kilogram per minute for all patients. That means that it is a weight-based dose. It should be increased by 8 drops every 2 minutes into a max of 0.5 micrograms per kilogram per minute. Pediatric patients require an online medical control order prior to initiation. However, you should make sure if they want to start norepinephrine in the field or you believe norepinephrine is indicated, you should immediately consult the medication guideline because the dosing is weight-based and more aggressive than previous. For sepsis patients, we have moved to ensure adequate infusion of 30 cc's per kg over 10 minutes using a pressure bag, the initiation of a second IV, and then after 10 minutes, if continued hypotension, the aggressive use of norepinephrine based on the previous weight-based guidelines that I provided you. Updated practical skills. There are multiple that really pertain to the pre-hospital provider, but we're going to talk about carbon monoxide poisoning, mechanical ventilation considerations, as well as needle thoracostomy. The crews may have multiple CO monitoring devices, including a RAD57 or a ZOL X series. The big thing that you want to take away from this is that based on the CO level they obtain, as well as some signs or symptoms, patients can be delineated to additional treatments. So this nice reference graphic in the middle is important to be able to reference. They talk to you about carbon monoxide poisoning. One thing you want to remember, if a patient has signs and symptoms of CO poisoning with a level greater than 25, and they don't meet any contraindications to being transported to a hyperbaric therapy, they can go to St. Luke's. Ventilator management and initiation is not something that our crews in Milwaukee County currently perform. However, we have a ventilator consideration guideline in which the crews can utilize an on-scene caregiver to help them troubleshoot a ventilator. They can also provide specific guidance if the ventilator is not working or if the crews are concerned about the use of the ventilator, they are to immediately remove the ventilator and utilize a bag valve mask over whatever other device it has to be utilized on that patient for. So we do not provide ventilator initiation or management. However, there are some ventilator considerations to help troubleshoot in the field for our crews. In regards to the needle thoracostomy, we have provided updated reference guidelines to keep our crews in the safe space. Over the age of 13 or at the age of 13, we recommend the use of the lateral chest wall for needle thoracostomy, remembering that is for treatment of tension pneumothorax, and the consideration for a tension pneumothorax that requires treatment would be a patient who has a mechanism to produce that tension pneumothorax, plus underlying vital sign indicators such as hypotension, hypoxia, severe tachycardia, or markedly elevated respiratory rates. Remembering that breath sounds can help you identify a tension pneumothorax, but do not tell you a tension pneumothorax is definitively there. Therefore, use mechanism plus vital signs to guide your crews to perform a needle thoracostomy. Tools are rapid documents that our crews can access to help them with critical decision-making and confusing checklists they've had in the past. One of the tools that an online medical control physician might consider using is the refusal checklist. It provides you information as to how to establish capacity with the patient, and then gives you advanced guidance as to what you can tell your crews to make sure that they do and document prior to a patient refusing treatment or transport. And finally is our interfacility transport guideline. This was updated this year. Interfacility transport is essentially movement from one healthcare facility to another healthcare facility. Commonly occurs from ER to ER or ER to inpatient hospital. If our crews are called to perform this, and the patient requires a specific intervention during transport, that intervention has to be within the Wisconsin scope of practice for their specific scope, either ALS or BLS, and within our OEM standards of care guideline. If those are not possible, then the hospital has to be able to send an eligible hospital staff to perform that intervention while transporting that patient. If either of those two things cannot be met, our crews would not be able to perform the transport for the interfacility, and the hospital would have to contact a different EMS agency. This can be difficult to fully understand as many of these cases are case by case. Remember to always perform patient-centered care on these patients and you will never go wrong. With that said, I would like to stop there. Please contact myself or Dr. Weston if you have any questions. Thank you very much for your time.